Bismillahirrahmanirrahim. In the name of Allah, who is the most beneficent and the most merciful. The thought of the day is when you face difficult times, know that challenges are not sent to destroy you. They are sent to promote, increase, and strengthen you. Assalamu alaikum. My name is Dr. Inshrah and I am a PGR of Community Medicine at Public Health at King Edward Medical University, Lahore. Today, the topic of my presentation is COPD and asthma, and I'll be presenting it under kind supervision of Professor Dr. Saira Afzal. Our learning outline will be introduction of COPD and asthma, global data, pathogenesis, causes, clinical features, diagnostic tests, treatment, recent updates, and then multiple choice questions. Our learning objectives will be, at the end of this presentation, the participants will be able to understand the definitions, causes, and pathophysiology of COPD and asthma, distinguish between the different forms of COPD and asthma, their epidemiology and clinical presentations, identify the diagnostic tests used to evaluate COPD and asthma, and learn about the treatment options and management strategies for both these diseases. Chronic obstructive pulmonary disease, COPD. COPD is a preventable and treatable disease characterized by persistent respiratory symptoms and airflow limitation due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. It is a progressive, non-reversible lung disease characterized by chronic airflow limitation. The primary cause is long-term exposure to irritants, especially cigarette smoke. It mostly affects individuals aged greater than 40 and is more common in males than females. COPD is the fourth leading cause of mortality globally. It is the eighth leading cause of poor health worldwide. It contributes to millions of deaths annually, with smoking being the most significant risk factor. Tobacco smoking accounts for over 70% of COPD cases in higher income countries. In lower and middle income countries, tobacco smoking accounts for 30 to 40% of COPD cases, and household air pollution is a major risk factor. This is a diagram that shows the prevalence of COPD age-wise in both male and female. Epidemiology. Globally, COPD affects approximately 200 million people and is the fourth leading cause of death. In USA, an estimated 16 million people are diagnosed with COPD, though the actual number may be much higher. In UK, over 3 million cases of COPD are reported. In Pakistan, cases are rising due to tobacco use, poor air quality, and indoor exposure to biomass fuels. COPD is estimated to cause 3.23 million deaths globally, according to World Health Organization 2019. This is another picture that shows the prevalence of COPD in higher income countries, lower middle income countries, and worldwide. You can see that in high income countries, highest prevalence is in European region. In lower middle income countries, highest prevalence is in Western Pacific region, followed by the Southeast Asian region. Worldwide, highest prevalence is in the Western Pacific region. Two forms of COPD. There are two major forms of COPD, chronic bronchitis and emphysema. Chronic bronchitis. It is characterized by persistent productive cough for at least 3 months in 2 consecutive years. There is inflammation and narrowing of the airways that leads to the obstruction, increased mucus production that causes persistent cough and sputum, often referred to as blue blotter phenotype due to cyanosis and fluid retention in severe cases. This is a picture that shows a healthy airway and then of a patient that has chronic bronchitis. You can see that there is inflammation and excessive mucus production. Types of chronic bronchitis. There are 4 major types: simple chronic bronchitis, chronic mucopurulent bronchitis, chronic asthmatic bronchitis, and chronic obstructive bronchitis. Emphysema. This involves destruction of alveolar walls resulting in enlarged air spaces. This leads to the loss of elastic recoil, reducing the ability to exhale air effectively. Commonly associated with the pink puffer phenotype due to pursed lip breathing and cachexia. This is a picture that shows a normal individual and this with someone that is affected by emphysema. You can see that there is loss of elastic recoil and fusion of the alveoli here in this picture. Types of emphysema. There is central SNR type, which is associated with smoking, pair SNR type, which is associated with alpha-1 antitrypsin deficiency, paraseptal type, and then irregular type. Chronic bronchitis and emphysema and their comparison. Chronic bronchitis is associated with clinical diagnosis, daily productive cough for 3 months or more in at least 2 consecutive years. There is the individual is overweight and cyanotic. There is elevated hemoglobin levels, peripheral edema, and bronchi and wheezing. In case of emphysema, there is mostly pathological diagnosis, permanent enlargement and destruction of air spaces distal to the terminal bronchiole. Individuals are usually older and thin. There is severe dyspnea, quiet chest, X-ray hyperinflation with flattened diaphragm. Causes of COPD include smoking, exposure to environmental pollutants, genetic predisposition, example given in cases of alpha-1 antitrypsin deficiency, occupational exposure, recurrent respiratory infections, environmental tobacco smoke, and low birth weight. Pathogenesis of COPD. First of all, there is chronic inflammation. Prolonged exposure to irritants, example given smoke or pollutants, triggers inflammatory response in the lungs. There is airway remodeling. This chronic inflammation leads to changes in airway structure, including thickening of the airway walls and narrowing of the bronchi. This is followed by mucus hypersecretion. Increased mucus production and impaired clearance contributes to airway obstruction and persistent coughing. Finally, there is alveolar destruction. Breakdown of alveolar walls causes loss of surface area for gas exchange, leading to emphysema and reduced lung function. These changes result in the hallmark symptoms of COPD, airflow limitation, and difficulty breathing. This is a picture taken from Tyler and Francis. In case of COPD, there is exposure to smoking, infection, pollution, or early life events. This leads to an oxidative stress, inflammatory response, impaired immune regulations, proteinase and antiproteinase imbalance that leads to endothelial dysfunction and vascular remodeling, mucus hypersecretion, and finally there is epithelial mesothelial transition that is affected. Pathophysiology of COPD. Airflow limitation because of narrowed airways, mucus plugging, and loss of alveolar attachment. Hyperinflation. Air becomes trapped in the lungs due to reduced ability to exhale, leading to lung overexpansion, that is known as hyperinflation. There is reduced gas exchange efficiency. Alveolar destruction and air trapping reduces the surface area for gas exchange, impairing oxygenation and increasing carbon dioxide retention. Finally, there is exercise limitation. The airflow obstruction in COPD significantly limits exercise capacity, causing breathlessness during physical activity. Stages of COPD. Following are the 4 stages of COPD according to the GOLD classification: mild, moderate, severe, and very severe. In cases of mild COPD, there is a reduction of, in cases of mild COPD, the forced expiratory volume during the first second, that is also known as FEV1, that is greater than or equal to 80% of the predictive value. Such an individual may experience mild symptoms such as occasional cough or sputum production. In cases of moderate COPD, this FEV1 is reduced to 50 to 79% of the predictive value. Symptoms become more noticeable, including chronic cough and shortness of breath with exertion. In severe cases, FEV1 is further reduced to 30 to 49% of the predictive value. Symptoms significantly impact daily activities with increased dyspnea and frequent exacerbation. In cases of very severe COPD, FEV1 is reduced to less than 30% of the predictive value. Respiratory failure or right-sided heart failure may occur, and the patient is at high risk for life-threatening exacerbation. This is a pictorial definitions of these different stages of COPD. Mild airflow obstruction. You can see this blue portion is the normal lung or shows the capacity of the lung for normal air exchange. In moderate airflow, you can see that this blue area has reduced. Here in the stage 3, it is further reduced, and in stage 4, you can see this blue area only in the basis. Signs and symptoms of COPD. There is chronic cough, sputum production, dyspnea, tachypnea, wheezing, fatigue, cyanosis, barrel-shaped chest, pursed lip breathing, edema, clubbing of fingers, and hyperresonance or percussion. Diagnostic tests for COPD. First of all, there is spirometry, chest X-rays, arterial blood gases, sputum culture, CT scan, and then pulse oximetry. Treatment for COPD. COPD can be managed but not cured. Treatment is different for each individual and is based on the severity of the symptoms. Early diagnosis and treatment can slow progression of the disease, relieve symptoms, improve an individual's quality of life, prevent and treat complications. Treatment options include smoking cessation, bronchodilators that include short-acting like salbutamol, albuterol or terbutaline, long-acting like salmeterol and formoterol or theophylline tablets, inhaled corticosteroids, combination inhalers, oxygen therapy, pulmonary rehabilitation, antibiotics in case of bacterial infections, mucolytics, vaccinations for influenza and pneumococcus, and finally surgery. These are the different treatment options. With increasing severity, we move from self-management education and smoking cessation to bronchodilators, to inhaled corticosteroids, to pulmonary rehabilitation, oxygen dependency, and finally surgery. Asthma. Asthma is a chronic inflammatory disease of the airways characterized by airway inflammation, hyperresonance, and obstruction, leading to recurrent episodes of wheezing, breathlessness, and cough, particularly at night or early morning. It affects people of all ages and contributes to significant healthcare burden due to frequent hospital visits and medication dependence. Despite being a manageable condition, asthma remains a major public health issue, especially in low resource settings where access to treatment is limited. Epidemiology of asthma. Globally, over 3 million people are affected by asthma. In USA, approximately 25 million cases, the most common chronic disease in children. In UK, around 5.4 million people are diagnosed with asthma. In Pakistan, there is increasing prevalence due to air pollution, allergens, and underdiagnosis, leading to a growing public health concern. Asthma triggers include cold air, food, molds, pollution, pollen, pets, infections, dust mite, smoking, exercise, medicines, and stress. Types of asthma. There are two types of asthma: intrinsic asthma and extrinsic asthma. Extrinsic asthma occurs in almost 70% of the cases, while intrinsic asthma occurs in 30% of the cases. Extrinsic asthma is initiated by type 1 hypersensitivity reaction induced by exposure to extrinsic antigen. Subtypes include atopic or allergic asthma, occupational asthma, allergic bronchopulmonary aspergillosis, personal or family history of allergic reactions. It develops early in life. Intrinsic asthma is initiated by diverse non-immune mechanisms, including ingestion of aspirin, pulmonary infections, cold, inhaled irritants, stress, and exercise. There is no personal or family history of allergic reactions, and it develops later in life. Atopic asthma. This is the most common form of extrinsic asthma. It is triggered by exaggerated immune response to allergens. It involves IgE-mediated hypersensitivity reaction. There is exposure to allergens like dust, pollen, pets dander, or mold that induces airway hyperresponsiveness, wheezing, and breathlessness. You can see this is the bloodstream, this is the tissue, and then lymph. Whenever there is some allergen or extrinsic antigen, it moves from blood to the tissues where it initiates the hypersensitivity reaction. There is production of antibodies that attach to the mast cells, and then the reaction occurs. Non-atopic asthma. It occurs without allergic sensitizations and is primarily triggered by non-allergic factors, especially viral respiratory infections. It is more common in adults, tends to be severe, and has a weaker response to inhaled corticosteroids compared to atopic asthma. Serum IgE levels are normal. Skin test is negative. No other associated allergies, and subtypes include drug-induced asthma or occupational asthma. Pathogenesis of asthma. The pathogenesis of asthma involves two components, chronic airway inflammation and bronchial hyperresponsiveness. The mechanism has been best studied in atopic asthma. IgE-mediated reaction to inhaled allergens elicits an acute phase response that occurs within minutes, and then a late phase reaction that occurs in 4 to 8 hours. In the airway, there is initial sensitization to antigen or allergen with stimulation of Th2 types T cells and production of cytokines, interleukin 4, 5, and 13. Acute phase response that begins in 30 to 60 minutes after inhalation of antigen. Triggers include exposure to allergens such as pollen, dust mites, pets dander, or mold. There is mast cell activation. The allergens bind to IgE antibodies on mast cells, causing degranulation. And then there is mediator release, histamines that induce bronchospasm, airway narrowing, and then leukotrienes and prostaglandins that increase mucus secretion and vascular permeability, leading to airway inflammation and obstruction. Clinical effects include wheezing, breathlessness, chest tightness, and coughing. Late phase reaction that occurs 4 to 8 hours after allergen exposure. There is eosinophil activation by inflammatory cells, especially eosinophils, neutrophils, and T cells that infiltrate the airways. Prolonged airway inflammation, tissue damage and edema due to release of cytokines and toxic granules, increased airway hyperresponsiveness, making the airways more reactive to triggers, persistent bronchoconstriction leading to chronic asthma symptoms such as wheezing, breathlessness, and coughing. Long-term effects include chronic inflammation that results in airway remodeling, fibrosis, and irreversible airflow limitations if left untreated. This is a picture that shows sensitization to allergens. This is a normal airway. This is the airway of an individual that has an asthma. You can see that there is constriction in the airways. First of all, there is immediate phase reaction, and then there is late phase reaction. This is increased mucus production. Clinical features of asthma include wheezing, shortness of breath, cough, chest tightness, increased respiratory rate, nighttime symptoms, difficulty sleeping, fatigue, cyanosis, and status asthmatic. Diagnostic tests include spirometry, peak flow measurement, methacholine challenge test, fractional exhaled nitric oxide FeNO test, allergy testing, chest x-rays, blood tests like eosinophil count, ABG analysis, sputum analysis, and then exhaled breath condensate. Treatment of asthma. Asthma management includes both quick relief and long-term control medications to alleviate symptoms and prevent flare-ups. There are 4 basic types of asthma medicines: bronchodilators that relax and open the airways to relieve asthma symptoms, controller medications that are used to reduce and prevent lung inflammations, combination inhalers that combine more than one asthma medicine in one, and then biologics that treat the specific cells and pathways that cause inflammation related to severe asthma. Acute reaction treatment. There are medicines that provide rapid relief during asthma attacks or sudden exacerbations. These include short-acting beta agonists, (GABA), like albuterol, anticholinergics like ipratropium, oral and systemic corticosteroids like prednisone. Continuous therapy for long-term control. These are the medications that help to manage asthma over time and prevent chronic symptoms. Among these are long-acting beta agonists (LABA) that include salmeterol and formoterol, inhaled corticosteroids like fluticasone and budesonide, leukotriene receptor antagonists like montelukast, biologic agents like omalizumab and dupilumab, and methylxanthines like theophylline. World Asthma Day. World Asthma Day is an annual global event organized by the Global Initiative for Asthma to raise awareness about asthma and improve asthma care around the world. It is observed on the first Tuesday of May every year. Activities on this day include public awareness campaigns, health talks and seminars, free asthma screening and checkups in many healthcare facilities, distribution of educational materials, and social media campaigns to spread information on asthma care. This is a picture that compares asthma with COPD. Age of onset in asthma, there is often onset in the childhood or adolescence, although it can manifest after the age of 40. In COPD, it typically occurs after the age of 40. Etiology includes allergic and non-allergic in cases of asthma, and then cigarette smoking in 90% of the cases in cases of COPD. Clinical progression. In cases of asthma, there is stable course of disease with episodic attack. In cases of COPD, there is insidious onset and chronic progression over years. Chronic productive cough is uncommon in asthma, common in COPD. Significant diurnal or day-to-day variability, nighttime waking with breathlessness and/or wheeze, atopic symptoms and seasonal allergies. All of these three things are common in cases of asthma and uncommon in cases of COPD. Obstruction is reversible in cases of asthma, irreversible in cases of COPD. First-line medications include corticosteroids in cases of asthma and inhaled long-acting bronchodilators in COPD. Moving forward to the recent update. Estimating the global prevalence of chronic obstructive pulmonary disease, COPD, a systematic review and meta-analysis. The present study aims to provide a global and regional estimate of the prevalence of COPD based on spirometry according to the two most widely used diagnostic criteria of COPD, fixed ratio and lower limit of normal. The overall prevalence of COPD in people aged 40 years and older was 12.64%, with 95% confidence interval of 10.75 to 14.65%, and 7.38% with confidence interval of 5.47 to 9.55% based on fixed ratio and lower limit of normal criteria respectively. By gender, men had a higher prevalence of COPD compared to the women, 15.47% for men versus 8.79% for women. Using the lower limit of normal criteria, the prevalence of COPD in both sexes was almost identical, 8.67% for men and 8% for women. We reported a high prevalence of COPD among smokers and the elderly by both definitions of airway obstruction. Regional prevalence estimates using the fixed ratio definition indicate that the highest COPD prevalence was recorded in the Americas and the lowest was recorded in the Eastern Mediterranean region. Using the lower limit of normal definition, the highest prevalence was recorded in the Southeast Asian region and the lowest prevalence was recorded in the American region. The most common COPD stage was stage 2, with a prevalence of 50.46%. The results indicate a huge lack of prevalence data in the African and Eastern Mediterranean region. Precision approaches to chronic obstructive pulmonary disease management. COPD heterogeneity has hampered progress in developing pharmacotherapies that affect disease progression. The issue can be addressed by precision medicine approaches, which focus on understanding an individual's disease risk and children management based on pathobiology, environmental exposures, and psychosocial issues. There is an urgent need to identify COPD patients at high risk for poor outcomes and to understand a mechanistic level where certain individuals are at high risk. Genetics, omics, and network analytic techniques have started to dissect COPD heterogeneity and identify patients with specific pathobiology. Drug repurposing approaches based on biomarkers of specific inflammatory processes, that is, type 2 inflammation, are promising. As large data sets, additional omics, and new analytic approaches become available, there will be enormous opportunities to identify high risk individuals and treat COPD patients based on their specific pathophysiological derangements. An international consensus on the use of asthma biologics in pregnancy. Asthma biologics reduce exacerbation frequency, are steroid sparing, and improve quality of life in people with severe asthma. However, evidence for the use and safety of asthma biologics during pregnancy is scarce, largely because pregnant women are excluded from clinical trials. To help to support clinical teams, we conducted an international modified Delphi study. 141 panelists from 32 countries who were involved in the care of people with severe asthma completed 2 rounds of online surveys covering key areas surrounding the use of asthma biologics in pregnancy. The results from this international Delphi study emphasized risk versus benefit discussions and shared clinical decision making, with consensus among panelists that asthma biologics can be used during conception and throughout pregnancy, initiated during pregnancy in line with prescribing criteria for non-pregnant people, and initiated or continued during breastfeeding. Now, MCQs. A healthcare provider is discussing the major risk factor for COPD in low and middle income countries. They emphasize that tobacco smoking contributes to a portion of COPD cases, but household air pollution is a more significant risk. What percentage of COPD cases in low and middle income countries attributed to tobacco smoking? A 10 to 20%, B 20 to 30%, C 30 to 40%, D 40 to 50%, or E 50 to 60%. The correct answer is Charlie. A 65-year-old man with a history of smoking presents with cough, increased sputum, and shortness of breath. His doctor diagnoses him with chronic bronchitis. What is the primary mechanism responsible for the symptoms of chronic bronchitis? A. Airflow inflammation and narrowing. B. Alveolar destruction. C. Bronchospasm. D. Pulmonary fibrosis. Or E. Pulmonary hypertension. The correct answer is alpha. A 72-year-old man with emphysema presents with difficulty exhaling, and his doctor explains that this is due to the loss of elastic recoil in the lungs. What is the primary cause of difficulty in exhalation in emphysema? A. Reduced lung compliance. B. Loss of alveolar walls and elastic recoil. C. Airway inflammation and obstruction. D. Mucus hypersecretion. Or E. Pulmonary fibrosis. The correct answer is beta. A 70-year-old COPD patient presents with progressively worsening difficulty breathing. The doctor explains that prolonged exposure to irritants leads to specific inflammatory response. What is the initial response of the lungs to prolonged irritant exposure in COPD? A. Increased lung volume. B. Acute bronchospasm. C. Chronic inflammation in the airways. D. Alveolar wall destruction. E. Improved airway function.
A.
Correct answer is Charlie. A 75-year-old COPD patient is hospitalized due to respiratory failure and right-sided heart failure. His FEV1 is less than 30% of the predictive value. What stage of COPD is this patient experiencing? A. Mild. B. Moderate. C. Severe. D. Very severe. Or E. End stage emphysema. The correct answer is delta. A 50 years old patient with COPD experiences worsening shortness of breath, and the doctor suggests a treatment plan tailored to their specific symptoms. Why is COPD treatment individualized for each patient? A. Because COPD is highly contagious. B. To minimize the cost of treatment. C. To fit the patient's lifestyle. D. To ensure faster recovery. E. Because treatment is based on the severity of symptoms and disease progression. Correct answer is eta. A 40 years old patient has been diagnosed with asthma, a chronic condition that causes recurrent episodes of breathlessness, coughing, and wheezing. What is the hallmark of asthma as a chronic condition? A. Asthma is characterized by recurrent episodes of wheezing, breathlessness, and cough. B. Asthma leads to irreversible lung damage. C. It only affects children under 10 years of age. D. Asthma symptoms are absent during physical exertion. Or E. Asthma always leads to hospitalization. Correct answer is alpha. A 30 years old patient with asthma does not show any allergic sensitization and experiences symptoms merely after viral respiratory infection. Serum IgE levels are normal and skin tests are negative. Which type of asthma is this patient likely suffering from? A. Atopic asthma. B. Non-atopic asthma. C. Occupational asthma. D. Drug-induced asthma. Or E. Exercise-induced asthma. The correct answer is B. A 50 years old patient with asthma is experiencing worsening airflow limitation and increased hyperresponsiveness of the airways after several allergen exposures. The patient has persistent wheezing and breathlessness. Which of the following most likely describes the cause of these long-term changes? A. Bronchospasm. B. Viral respiratory infection. C. Acute inflammation. D. Chronic inflammation and hyperresponsiveness. E. Normal airway function. The correct answer is delta. A 40 years old patient with severe asthma has not responded to traditional asthma medication. The doctor recommends a biologic agent that specifically targets inflammatory pathways involved in the patient's asthma. What is the primary function of biologic medications in asthma treatment? A. To reduce mucus production. B. To increase airway diameter. C. To decrease the need for inhaled steroids. D. To provide immediate bronchodilation. Or E. To target specific inflammatory pathways. The correct answer is eta. This is the key to all MCQ. This is the link to our YouTube channel where this presentation will be uploaded. Thank you for your attention.